Great. Welcome back to the House Healthcare Committee. We're continuing our budget discussion. So here is what we have left to do this afternoon. We have the governors recommend that we have ranked as high, medium, I don't think you have anything low. And so we're going to take the highs and do the same 1, 2, 3 that we did on the non-governor recommends. We have that to do. Then we still have to decide on a by-state number. I want to talk about Soterra House and the one-time funding study for EMS. And then we have some language to go through that Jen will walk us through. And anything that I am forgetting. So I'm gonna tee up Nolan to start the spread. I'll give you the stuff and then maybe we'll switch to by-state and come back to you. So we're gonna wanna do the same thing we did, and these are the choices. The dental rate increase. The mobile crisis, the 988 line, the peer support, and the therapeutic.
Second, again, dental.
Dental, mobile crisis, 988, peer support, the therapeutic alternatives. You have all of them?
I do.
Okay. So then we'll do that first. So I'll say them again for everyone. It is the dental rates, the mobile crisis, maintain the 988 line, the peer support credentialing, and the therapeutic alternatives.
Ranking those?
Ranking those. So we will give Nolan our first, second, third choice.
I get low priority.
High, mid, low. So just go, your order. Highest to lowest. You don't have to give a number. So record it, and that is how we will come up with our 3 high ones. Dental rates.
Mobile crisis.
Mobile crisis, 988, peer credentialing, and therapeutic alternatives.
I'll go if you're ready.
Nolan, are you ready?
Yes, I am ready.
Okay, first one for me is therapeutic alternative.
Okay.
Second is dental rates. And third is maintain 899 suicide line.
Okay. Got it.
Whoever's next,
I'm ready.
go for it.
Number 1 is dental rates. First.
Okay.
Second is maintaining 988. Third is Northeast Kingdom therapeutic alternatives.
What, you ready, Nolan?
Real quick, yours was therapeutic, dental, then mobile, then 988, right?
Yes,
Okay.
yes. Yeah.
And then, let's see, you were dental, 988.
We had a different order.
Okay, just making sure I didn't do 1, 3 instead of 3, 1.
Yep.
All right, Ellen?
Therapeutic in the kingdom.
Hold on, sorry.
I'm just gonna go check to see if Brian wants to.
Okay, I got it.
Okay, and number 2 is 988.
I can hear you.
And you can't,
You don't have to come. I'll come there in a minute.
Okay, great. I'm sorry, Alan, what did you say?
It said the therapeutic alternatives in kingdom. 2 was 988 and 3 was dental. Right?
Okay,
okay, you got it.
who's next? Bobby?
I'll go. The therapeutic alternatives is number 1. Second one, dental rates, and third, 988.
Okay,
I'll go. My first choice is dental rates, second mobile crisis, and third is the peer support credentialing.
okay.
Mine was exactly the same as Leslie's.
Okay, so
Dental mobile pier. With a candlestick.
In the lounge.
okay. Who's next?
Anyone ready?
I'm gonna go Piers, therapeutic, 988.
Piers Therapeutic 98. Got it. Hopper and Laurie
I know.
by Representative
Brian?
McConnell.
You ready? You want me to go? I am going to do, dental. So hard. Therapeutic alternatives and mobile crisis. No.
Not too late.
Nope. I'm gonna put, instead of mobile crisis, peer credentialing, please.
Okay, so let me start over. The dental.
Dental, therapeutic, peer support.
Here's-
No, sorry. I'm going back. I meant mobile crisis instead of peer. It's like when I order dinner, I go like 5 different ways. I'm done now. Thank you.
Can I go?
Sure.
Hold on. I don't have to.
I am gonna let him do this since he is next door. Does anyone have a problem with that? Okay.
Makes perfect sense.
Just give me a second to add.
Are we sure it's Brian?
Yeah. You see him now, so. 1 second, Brian. He's, no one's,
Yeah, I don't mean to impose. I just,
no, just get 1 second.
Give me 1 second.
Thanks for coming on screen.
Okay, Representative Chin, I'm ready for you.
so, just to clarify, what I was watching all day, we're not saying we don't support other things. We're just ranking the top. It's like ranked choice voting, basically.
Yes, exactly.
All right.
The top 3.
So peer support credentialing, mobile crisis response, therapeutic alternatives in the Northeast Kingdom would be the top 3. Thank you.
Okay.
In that order, I take it?
Yes.
Okay, thank you.
So this was peer, mobile,
Therapeutic.
therapeutics. Got it.
Hopper?
Yep, dental rates,
Mhm.
mobile crisis center, and therapeutic for the Northeast Kingdom.
Okay. And that's it. All right. So dental came in the highest, 20, followed by therapeutic because of our strong Northeast Kingdom contingent. And then mobile crisis came in 3.
Alright. And can you send me an email with all of that, so I have the top, all of them, not just the top 3? Thank you, Nolan, so much for making that happen.
What were 4 and 5?
Then it was credentialing at 8 and 98, 7. Everything was close.
Yeah.
Well, dental and therapeutic were the clear winners.
So my intent is to put our top 3 listed on this chart, and then put a context at the bottom with both, so that the committee can see that it was all really close. Okay. All right. One-time funding, one-time study for EMS, and then the Satara House. So we didn't actually, talk about those because they were, wait, remember, what did I do? 1, 2, 3, 4, right. So we had done, our top 5, which was VMS, primary care and specialty care, the EMS at 100%, Vermont Care Partners at 4%, home health, and by state, although we haven't come up with a number yet. And then we had ranked choice voted on those, and it came out to the primary care and specialty care, the EMS at 100%, and home health. We breezed over EMS and Sotera, and the reason I did that was because they were one-time funding requests versus in the base budget, which all the other ones were base budget. So I want to come back to that and get a feel for what people think about them. One, we can do a straw vote if you want, if we think they should be included. And then two, do we just include them? Or do we say, these are such high priority for us, if you need to find one-time funding, we want you to take it from the 10 million emergent care fund. Alyssa.
May I clarify the EMS one-time 100,000 for study? Was
Yeah.
that, did we vote on that inclusive in the 100% rates?
We did not.
So do we want to include that as well?
That's what I'm
in the
talking
one-time?
about.
Okay,
That
I'm
and
sorry.
that and the Sotera House.
Yep.
Oh, I thought, wasn't there another one-time?
Just those two.
Mm-hmm.
Oh, I think I was thinking free clinics, but.
Yeah, that's base
One-time,
funding and that's going in the high.
Yep.
So I guess the first question is, so if you remember, the one-time funding for the study is so that we can, they can hire a consultant to get the data they need to look at our EMS system. I reached out to Vermont Department of Health, because normally when we put language in a bill, we should get testimony. And their response was that they do not have an, actually, let me get the exact language, so I am. Sorry. I'm gonna find the exact language while we talk. But they had no comment, basically. So let's stick with the Sotera House first. Do we consider it a priority of this committee to put it in the budget with one-time funding? So I guess I would say, I'm gonna simplify. All those in favor of including it? Question? Yeah.
Sorry, not a mask, happiness person. I'm interested in hearing from our people who know about mental health.
Okay.
And, you know, sort of like if people are willing to give a thought on it.
On the Sotera House or on mental health?
On the Sotera House, in the context of our mental health system. It seems like a very small increase in beds. What's the actual impact? Is it have enough value to support, I guess? Is that fair? Or maybe not?
I think it's fair if I would say Brian wants to respond. He's probably the only one in the room to have a working knowledge of Sotera House. So Brian, do you feel comfortable?
Yes, yeah. I didn't know if Leslie, if you were requesting like a non-legislative witness, or if you wanted to hear from your peers on it, but I'm happy to share. And then if we want to hear from others, we can ask them if they're not in the room, but.
Peers, Brian.
Okay, so I would say that that peer-run services like Sotera House are the future, and that the effect, it's hard to describe the positive impact they have. Like, I don't know if there's studies or research to look at, but I can tell you that for a person who has psychosis, especially their first time, if they can go somewhere where they're in a community of people who embrace them and help them make meaning of their experience and support them in feeling empowered in finding a path to recovery or to like a better quality of life, that is a world of a difference from what we used to do, where a person would be locked up and their rights restricted and treatment was forced on them. And I think we need more places like Sotera. And in terms of the effectiveness in the long-term trajectory of somebody's like treatment and prognosis. And then in terms of the bed availability, as a clinician, I see a fair amount of people in the hospital who have psychotic symptoms. And a lot of the people who have those psychotic symptoms end up in the emergency room because they don't have a safe place to be where they and others are safe. So they might be homeless, or they might not, their family might say, we don't feel comfortable having them here right now because of the way they're acting. So they bring them to the emergency room, and then there's nowhere else for them to go. So they stay there, and then they might go somewhere, and then they go home and it happens again. But somewhere like Soteria provides longer term treatment, where a person can be kept, can be like held. And when I say held, I don't mean against their will, but held, it's like hugged, like supported, held, through that time of their life. So I think this is a great chance to explore like what happens when we expand a peer service that's working. And the idea that they're buying the infrastructure, it's an investment in like bricks and mortar that is significant if they can double their beds. And then if that other site eventually turns into some other kind of residential option, that could potentially open even more beds up in the system. So I guess long story short is I think that it's not only the socially responsible and clinically effective thing to do, but it's also the fiscally responsible decision to make. That's my pitch for voting yes on it.
Thank you.
Thanks.
I would back Brian up too. And as someone who's worked in systems improvements and, nationally and then within states, this is, as Brian noted, the direction of the future. That's why we see federal funding backing that statement up. We see models like CCBHCs that actually require peers at every level of care, just like Vision 2030, the Department of Mental Health's vision of what the mental health care system will look like in Vermont in the future. So I think this aligns with, the direction that we want our system to go, but also we as people want our care to feel like. And it is cost effective too. And that's a bonus when we look at budgeting. I don't know if that's helpful, Leslie.
Very, thank you. Now I know where I want to go. I'm done.
Okay. So are we, Alan, I think you wanted to say something.
Well, I don't know if I do.
Okay.
I understand it. I know the importance of it, and I do. And I think if I remember the other day, her talking, there's 4 or 5 there now, and there will be room for 4 or 5 more.
Yes.
And
There's 5 there now, would be room for 4 more.
there's about 45 other people through the year that would like to have access to that. But we're trying to put things into importance. And we just said, by state, we overlooked that, Vermont Care Partners, and we've overlooked them. It's going to have impact of hundreds and thousands of people. And I'm not trying to put one against the other, but are we getting the best for our dollar?
Okay. Bobby?
Well, I just want to add that we spent $9 million for a 9-bed facility, and this is 4 more beds for $1 million. So it's like each bed is at a quarter of the price.
Feasibility study.
And I'm not against it.
Yeah.
Well, no, the 9 million wasn't for a feasibility study.
Yeah.
9 million was once we knew what the feasibility study told us, the money would be available to do some of the beds, which we're going to come back to because that did not make it through BAA.
Oh.
But I appreciate your point.
Yeah, and then the other thing is that keeping folks there, it costs a quarter of what it does at the hospital. So when you put that into account too, we're getting, a really good bang for the buck, like I said before. So that's.
Brian, is that what you were going to say? Or do you want to comment?
Kind of. I mean, I don't know exactly what an emergency room visit costs at this point. I was told it was over $2,000 a night, but I could be wrong. So I don't want to be wrong. But even if it's a little less than that, one night in the emergency room is more expensive than a month's rent for a person in Burlington, where this place is going to be. And if a person who's staying there was going to be bouncing in and out of the emergency room even one night a month from any other setting, it's more expensive for the system, and they're taking a bed that someone else could be taking. So I just think in terms of the flow, it makes sense. So it kind of adds to what Bobby was saying. So.
Yeah, I'm kind of with Alan. I think it's a good thing. I think it's a great thing, but everything on here is a great thing. What I'd like to know at this point, we've gone a long way through. Of the dollars, what are we talking about for overall dollars that we have added to the governor's budget, the administration's budget? And how do those dollars compare with last fiscal year's ask? I know we got a chart from Claire, you Alyssa got one. But that's only Diva, I believe.
That's the Viva budget.
And it's an overall cost, so it's tough to tell, but I'll tell you, at this point, I would like to see where we're at.
So-
We pumped a lot of money into this.
So once we're done with the spreadsheet, we can give you a total of what we're recommending goes to appropriations. I don't have the ability to, and I don't think we should compare to what we recommended last year, because it's totally different projects and so, and what we recommended is
Yeah.
not necessarily what made it into the budget either. So
Correct.
there's really,
Well, right, okay, yeah, I mean, it'd be good to see what went into the budget from this office, from this committee last year. As far as what was recommended, I get it, that doesn't matter. It really matters what went in so that we have some sense of where we're at. I mean, maybe we're way off, maybe we're asking way too much. I don't know, maybe we're too little.
so I'm gonna go back to, we put forth a budget to appropriations,
Yeah,
and they have an even harder time than.
well, I know they do. I mean, it's all tough all the way through, but I get, it's the same old thing. I mean, you just get nervous continually and add $1 million to the thing and millions and millions and millions, and pretty soon you got a lot of millions.
So just remember, yeah, we do have a lot of millions. And I would say we have a lot of millions because we're underfunding our system. I mean, I think we've all kind of agreed on that today. So appropriations will take all the recommendations. They have a box they're working within. They will go to the Senate. They have a box they're working within. And then frankly, there's a box we're all working within because there's the administration that still has to sign the bill. So there are three parties in this process. We're one piece of the puzzle.
Okay,
I know.
Well, that's
I know.
sense.
Go ahead.
I remember when Soteria House first started, and it was started kind of on a pilot type thing to see if it would work. And it has worked, it's stabilized, it had its own place. And they've done a good job. They keep people out of the hospital, which is very costly. And this seems like a normal progression of a different way to treat these people. And it may be part of it will be part of the future and how we provide services to these people. And it's a hell of a lot cheaper than going to the emergency room. And I think everyone that's talked has mentioned that. But I see it as a program that worked, and when you find these things, you should keep going, in my opinion.
Especially in the community.
Yeah.
I feel like I worry when I hear about, and I've learned so much just in the last few weeks about how many providers across the system are struggling. I worry about things happening in Vermont with mergers and acquisitions. Acquisitions might be harder in the state, but I worry about other people from outside coming in and merging our system so that we're no longer talking to people like Hillary Melton from Pathways about Soteria and learning firsthand from someone who's been in that seat for decades and can tell us the evolution of Soteria House. And instead, we might be hearing from a CEO who sits in North Carolina and now owns our hospital system here. What I'm saying is I love the fact that we've gotten to learn about providers in Vermont and how they've built the systems that we have the opportunity to help survive right now.
Okay, so we're gonna do a straw vote. All those in favor of having Soteria House be a high in our plan?
I have a question, sorry.
You mentioned about,
Voting.
well,
We're voting, and then we're gonna,
about taking money from elsewhere.
I just wanna know if it's a high, and then we're gonna talk about that.
Okay.
Okay, so that's a yes. All right, EMS one-time funding, I'm coming back, Leslie. EMS, $100,000 for a study that will help us figure out how to shore up EMS. The department's response, Vermont Department of Health said the department will not be providing testimony on the proposal.
Question.
Yeah.
Was this about the attempt to look at a regional system and sharing resources?
Yes.
That would be part
What'd you say, Topper?
of it, yeah.
Yes, part of it was, yes. And the reason they're asking for the money to do it is that the EMS commission doesn't have, they're all volunteers. And a lot of the individual EMS units are quite small and quite understaffed and quite overworked and haven't been able to gather the data that the commission really needs to do a look. So the other option is on this, is to table it, not include it in the budget, and we take it up when we take up the EMS bill. What that means is it's not going to be done before crossover. So it would be a bill that would, if we pass it out of committee, would go to the Senate, and they may choose or may not choose to take it up this year, so it would fall into next year.
We should do it now. Yeah.
Brian?
How come we couldn't just quickly try to move the bill since we've already heard some testimony on it?
Honestly, because I'm making our suicide prevention bill our priority before crossover. Based on all the conversations we have had. And we only really have tomorrow, Friday, and 4 days when we come back from break. There's too much more in the bill to take up before then. Leslie?
So according to this, it says there is created the Regional Emergency Medical Services Coordination Study Committee to assess the current EMS district structure and the current level and cost of service in each district.
Yeah.
And I'd like to include that in this budget,
Okay, so we're just,
if you're asking.
doesn't seem to be much discussion, so let's do a straw vote. I'm gonna do high, medium, and low. Unless high wins or medium wins. So to include it in the budget as a high. All right. So my next question is, we just leave it in as a high and let appropriations decide, or we can say it is such highs for us that we would be willing to have you move money out of the $10 million to that if they needed to find one-time money. And the $10 million is the E1100A16D to address emergent and exigent circumstances impacting healthcare providers.
I think that also speaks to the need of the urgency or importance of all the other things that we're asking for too. Right?
What does?
Saying you can take this out of the 10 million.
Yes, I think if we say that, it's showing a bit more oomph behind Soteria House and EMS that we're trying to do. Brian?
Yeah, I also would argue or advocate and say that the investment, and this is maybe bordering into the capital bill a little bit, but I'll say it and then we can figure out if that's the case. But I think for the EMS funding, it definitely seems to align with the idea of money needed with the last thing you said about the contingent, but in terms of Soteria House, it's like a capital expense. And even though it's like an infrastructure expense, and even though I don't know if capital bill money can be used for that.
No, I already checked, it can't.
Okay.
Because it's not our building, it's not a state building.
Okay, and maybe I'll explain why I was saying that briefly, just to put it out there, is that we're looking at building a new prison, or a reentry facility, but some of us are advocating that we don't do that and we instead look at other kinds of housing And if there was more housing for people who had psychotic illness that could support them, the behavior that comes along with that illness that might result in being involved in the criminal justice system would be reduced. And even if it wasn't, there'd be a safe place for someone to go when they do get in trouble, rather than people getting dumped into jails, which is expensive, like our emergency rooms. So that's why I thought of that. But if it's not able to be used from there, I get it. But we might want to somehow consider, how do we make the argument that these investments in health and human services are going to prevent needed expenses in the capital bill down the road, you know? So.
Right. No, and I appreciate that, because I did check with the chair of that committee. All right. So it's going to be one of two questions. Yeah, go ahead.
Do we have any information on what that 10 million is currently like estimated to be spent on? Because I understood from our conversation earlier that there were already requests.
So there is, according to AHS, there are people who have entities that have applied through the process. And so they have about 16 million sitting there in requests that they haven't committed to, sitting there. They have 4.1 million left over from the last pot of money we gave them.
Do we know what entities?
No, we don't.
For example, I personally wouldn't want to say you can take EMS and Soteria out of this if I knew that all that money had been offered up to our mental health agencies, since the administration really didn't include a lot of equity, in my opinion, in this budget for mental health agencies. So that's my opinion.
So you would not be in favor of saying we should take the money out of the 10 million?
I would like to see who those 16 million in requests are from.
And we don't have that capability. We have to make a decision without that, unfortunately, without that information. I mean, I think, go ahead and read what it says again.
Considering 16.5 million one-time proposals to improve flow and reduce pressure due to unmet mental health and long-term care needs.
Mental health and long-term care.
Where are we?
That's for the $10 million. So what?
One-time ask.
Yeah, so there's the one-time ask for 10 million.
Okay.
I'm throwing on the table. We either just put in the EMS and the Sotera at a high and we leave it at that. Or we say, we value that so much. If you need money, go to the one time. Now, I personally would probably just leave them in as highs. But I want to, throw it out to the team to say, if this is so high, let's tell them where they can get the money. But we're not telling them where they can get the money for anything else. So.
Just don't supersede the other.
No.
Okay.
Okay, I'm lost. So we're not gonna do the 10 million.
No, we are doing the 10 million.
Or you're gonna do it.
We agreed that the 10 million is a medium. All right, so I'm actually withdrawing my idea. We're just gonna put them on as high and go with it. Okay, so EMS one-time funding is a high, Soteria House is a high. We're not changing any of the rankings and we're not taking any of the money from the 10 million. Okay. Last thing to do on the money side, and then we're going to turn to language by state. So remember.
Where are we? I missed that.
So by state, the FQHCs, second to last row under the non-government, we have it as a high. It did not rank as one of the top 3, but it is still considered a high, along with Vermont Care Partners, which also did not rank in the top 3. And so this is where we need to look at the money and say, do we want to accept the proposal from Bi-State at 6.9, or do we want to reduce it for our letter to appropriations? I'm putting on the table that we reduce it.
So can I ask again, perhaps someone could weigh in? You said that the 6.9 I mean, I understand the difficulty of calculating that, but you think it's about a 20% increase over what your current rate is.
Actually, looking back at my calculations, it's over the 2022 rate, so it's about a 17% increase over what was currently paid in 2023.
Okay. So we're contemplating a 17% increase when we just gave our top priority essentially a little bit more than 3.8, or we went in with 3.8. I'm not quite sure what it calculates out to be.
Right.
So I'm very supportive of some sort of funding, but certainly not at the amount
Nolan
requested.
said, well, freelancer. Nolan said that 4% was, I forget what you said.
1.4.
Well,
It's like 2 points.
It's about
1.7.
1.6 now with
I'm sorry.
the
I didn't hear.
Mary Kate's. 2 million? 2 million.
2 million all funds.
2 million all funds.
What would the general fund be?
Times. No, I think
That's your job.
no,
It's 6.
Have that number as a copy paste.
it's 869, 600.
Any thoughts?
I think
So
that, yeah, I think the problem is that we don't know the baseline of where they started compared to the other, the primary care, et cetera. So if they got that far behind over the years, these percentages don't necessarily sort of match. However, that said, 17% is gonna be like really hard to do. So I am very happy to do a percent in some kind of consistent way, and 4% might be, but I'd like to include the legislative language to have a really deep dive into how we fund this so that we can start moving forward in it in a bigger way.
So on the language, I've talked to Mary Kate. DEVA was not accepted of the language that the bi-state wanted. And so I checked with bi-state, and we're not going to include any language. We're going to have a meeting about it.
Okay.
Because there's misunderstanding, there's misunderstanding between the two parties of what is being worked on. And so therefore I don't want to include anything that's controversial in this.
Okay, that makes sense. So what happens as the process has to move forward between the three of you guys?
Yeah.
Great, thank you.
And if we pick.
So there's 4% on the table, which is about, again, it's not apples to apples at all. But so the proposal on the table is $2 million all funds, 869,600 general fund.
Double that would be half of what they've asked.
Yes,
That's what I would propose.
half of what they've
I would
asked.
propose half.
I propose 10%. The primary care system is in such dire straits.
So what's 10%?
4.17, I'm just looking over her shoulder. 4.1, 4.2, 4.17 basically.
Which is very close to what the two of you are suggesting. Art was suggesting about 4, that's about 4. What is,
I'm getting there, I'm doing it.
What did our final,
1.814. General fund.
1.8, okay.
what did our final numbers under the
Well, that-
primary care RBRBS, what did that land us at as an increase? Oh, I don't know. I mean,
Did you 110?
We did 110% of
we did
that.
110.
1755410 is the all fund. So 1.8 million all funds.
I know we're trying, we are to find a rationale, but it is very hard to do across the different ones because the FQHCs are so different.
I think the 4% is equitable.
So we have 4% on the table and which is,
I'll support 4%.
okay, all right.
Support 4% as well.
Brian, did you have any comments?
I just, I understand that there's a limit, you know, I understand what it's like personally to have to live within my means. But I do think we need to give rate increases to those who we've neglected as much as we can. So whatever that number ends up being, I'll support it, you know, whether it's 4%, 10%, whatever. So that's all I want to say about the percentages.
Okay, so we're gonna put two things on the table because that's what we've got and we're gonna vote. So so we're gonna do who's in favor of a 4%, which is about $2 million all funds? And who wants 10%, which is about 4.2? 4.2, all funds. So who wants the 10% of 4.2? 4. Who wants the 4% at 2 million? Okay, that one's the
Can we
one.
go to 6?
Nope. We suggested that earlier.
That was an auctioneer.
7.25.
The 2 million. The 2 million. I mean, yeah, the 4%, yeah.
You're gonna do 4%.
Brian said something and I didn't hear what he said.
What, Brian?
Oh, I was just trying to bargain. I said 7% because it's in between 4 and 10.
Yeah, Maureen came back with 6. I said, too late. All right, language. So thank you, everyone, for that.
So what really happened, is we went 4% for all of the primary care stuff, right?
Yeah, well, I don't know what this percent, we did 4% for Vermont Care Partners and we did 4% for Bison. This went up to 110, but I don't know what it is as a percentage increase.
Okay.
Are you
So
thinking of the Medicaid?
this one is 4%. The specialty care is 3.8%.
Yeah,
I'm not sure what this top primary care is,
okay.
but it's pretty, yeah, it's pretty close.
And that's all.
Specialty care.
primary stuff.
Yes. Except for FQHCs. Yeah. So we give
Which I
Jen,
think that's a good thing.
Madam Chair, can I ask a clarifying question on the governor's priorities? I apologize for jumping in. Did the blueprint?
the blueprint is in at high, and it's one time.
Not ranked because it's one time.
Exactly.
Thank you.
Yep.
Just to clarify.
All right, so we are gonna turn to Jen when she's ready.
Yes.
We have posted some language on the web committee page, whatever we call it. So while she gets set up, we have 5 things to talk about. So while she gets set up, there is one other piece. So the 9.5 million that we had put in the BAA for the youth psychiatric beds, the conference committee, I don't know if they've signed off, but I know that the money is not in it. Although the money did not make it through the BAA. The 9.5 million for youth psychiatric beds that we put in the BAA did not make it through the conference committee. However, they are indicating that they want to find a place for it in the budget. And so if we are still advocating for that 9.5 million, I would like to.
Sorry, it unmuted.
That's okay. I would like us to consider adding very simple language in one of these rows that says healthcare committee still supports 9.5 million to be held for youth psychiatric beds.
Could we add words like, we really need this?
Well, yeah, I mean, we could. What I don't want to do is wordsmith it. I really just want to say, this was what we put forward as a committee through the BAA, and we still think it's a priority.
So that money could be held to when they have an adequate.
Yes,
Okay.
yes. just like it was in the BAA, but it would be,
Okay.
and it would go through the same process and then it may not end up there. And we don't have to put it in,
No,
but I want to say that a recommendation from this committee, if it's a majority, recommendation, I think would be important.
Can we just add the word high? It's a
Yes.
high priority?
Leslie, I'm sorry, Topper, you first.
They're in the process, unless I read it wrong, they're in the process of doing this study.
Yes,
So, I mean, if we're letting that go forward, I think we should
right.
put the money aside.
And I think, it's all timing, right? So if we don't put it in the budget, which starts July 1st, if it's not in there and they determine that they can do it and they, even could probably open in November, they wouldn't be able to because they'd have to wait till we come back and do the next year's budget. So again, it's all this timing issue. Leslie?
It's a really different context now than it was then, because $9 million could then take the place of all these other things that we cared about, which weren't on the floor or in the discussion when we did it in the BAA.
Right.
So that's a struggle for me. Because I know that's important, I guess, we cared about it, but as I say, the context is different. So it's not an automatic for me, I'll just say that.
That's fine. But it's a straight up, majority supports putting simple language in that says we continue to support the use psychiatric beds or we don't.
I'm for
I
it.
just want to say, and the point is, if it wasn't in the BAA, then the administration would have come in and put it in their
Exactly.
one-time budget. So we'd be dealing with it right now anyway.
On the DMH.
Well, because they thought it was in the BAA.
Right, so they put it in the BAA was their intent, right? But the budget's already through once the BAA happened. So we don't really know what they would have done, but if it was still a high priority for them, it would have probably landed in the budget. All right, so we're just gonna do a straight up vote on this one. So all those in favor of putting a simple row with language that says we still support the 9.5 million beds, raise your hand. Okay.
The Muppet Show.
9.5 million beds. That's what we need.
That's what we mean.
9.5 million per bed.
We see the world. Come on, under the Vermont, everyone.
So Jen, thank you. I think you notated that.
I did. I'm trying to decide whether it goes under one time or not in governor's recommend, but we'll figure that out.
Okay.
Governor's recommend BA.
Yeah, exactly. Okay, so let's go through the language. Does everyone have it up? It was under Jen's name on today in the committee page.
I put it up too.
So while everyone finds it, we can walk through it. So I'll just set the stage. So this hospital system transformation language is what we talked about way early this morning. It seems like forever ago. Where we're simply, AHS and Green Mountain Care Board came to us and asked us to accept this plan. The chair of appropriations, the chair of Senate Health and Welfare, and I accepted the plan. We just need to put it in language.
Okay, so for the record, Jen Carby, Legislative Council. This is hospital system transformation planning language, as the chair said. This would direct the Agency of Human Services in consultation with the Green Mountain Care Board to engage in transformation planning with up to 4 hospitals or more than 4 hospitals to the extent funding is available. That's not quite what their language said, but I think it's what it meant. To reduce inefficiencies, lower costs, improve population health outcomes, reduce health inequities, and increase access to essential services. This is all language that was in Act 167 of last year, while maintaining sufficient capacity for emergency management. The transformation planning shall be informed by the data analysis and community engagement process set forth in last year's Act 167, Section 2. Then it says, in order to ensure alignment across hospital system transformation efforts, the Secretary of Human Services or designee and the chair and staff of the Green Mountain Care Board shall consult regarding the planning activities set forth in this section and the data analysis and community engagement process set forth in Act 167. Then on or before February 5th, 2024, the agency, 15th, 2024, the agency in consultation with the board would provide an update to this committee and the Senate Health and Welfare Committee regarding the progress of the hospital system transformation planning activities described in subsection A.
Great. So my intent is really not to wordsmith this, it's just to make sure everyone understands what we're doing. Okay?
All right, next we have blueprint payments. This was based on some of your conversation this morning. This would have on or before January 15th, 2024, the Director of Healthcare Reform and the Agency of Human Services recommending to this committee, the Appropriations Committee, and the Senate counterparts, including Finance, the amounts by which health insurers and Vermont Medicaid should increase the amount of the per person per month payments they make to Blueprint for Health patient-centered medical homes. So we talked about how last year's had the community health teams. In furtherance of the goal of providing the additional resources necessary for delivery of comprehensive primary care services to Vermonters, and in order to sustain access to primary care services in Vermont. The agency would provide an estimate of the state funding that would be needed to support the increase for Medicaid, both with and without federal financial participation. And then this piece is new. The agency shall also evaluate and report on potential mechanisms for ensuring that all payers are contributing equitably to the Blueprint on behalf of their covered lives in Vermont, including a consideration of supporting Blueprint initiatives through the healthcare claims tax that's in Title 32.
So so there's no money here. What we're asking is that they come back to us in January of next year. The same way so we did this before around the community health teams last year. Now we're saying, okay, we weren't really explicit in that. We wanted them to look at this piece too, and they didn't, which is fine. It wasn't in the language. Now we're asking them to. Any concerns?
Okay. Next week.
I'm concerned about what's going on in the other committee. I hope everybody's okay.
Okay. All right, EMS.
EMS study. So this, I just plucked the study language right out of H263, which is a bill on your wall, on the Regional Emergency Medical Services Coordination. This is a study committee to assess the current EMS district structure and the current level and cost of service in each district. The membership is a member of the House and a member of the Senate, appointed by your respective appointing authorities. The EMS chief of the EMS office in the health department, the commissioner of health or designee, the commissioner of public safety or designee, one member appointed by the Vermont League of Cities and Towns, one member who is a volunteer emergency medical technician or paramedic appointed by the Vermont Ambulance Association, one member appointed by the Vermont Association of Hospitals and Health Systems, one member appointed by the Vermont State Firefighters Association, one member appointed by Professional Firefighters of Vermont, one member appointed by the statewide EMS medical director, one member appointed by the EMS Education Council, 3 members representing 3 separate EMS districts with at least one selected district primarily covering small rural communities, appointed by the EMS chief at the Department of Health, and 2 members of the public appointed by the governor. Would direct this committee to study the provision of emergency medical services in the state, including the following issues: ways to decrease costs, ways to improve EMS coordination, ways to increase access to emergency services within each district, and ways to optimize the EMS district structure and authority, including consideration of recommendations on the number and configuration of EMS districts and their powers, duties, and authority.
Can I ask a question about that? I'm sorry. Mm-hmm. So one of the issues for EMS, if I understand it, is they don't get paid for transport. Does that fit into this study?
So they could look at that as part of the overall study. The EMS bill that either us or GovOps will be taking up has that piece in it.
Okay, so that
They don't
wouldn't
get paid for
necessarily.
transport to an alternative to a ED.
Or they don't pay if they just give.
If they just do treatment.
Yeah, but that wouldn't be appropriate for this study.
That's not necessarily what this study is directing them to look at. It's looking at district structure and the costs of services in the district, not necessarily how they are being.
I just didn't want to lose track, but thank you.
All right, so that gives the committee the administrative, technical, and legal assistance of the Department of Health. And it would have the committee submit a written report by the end of this year to the GovOps committee, this committee, and your Senate counterparts with its findings and any recommendations for legislative action. As the EMS chief, calling the first meeting of the committee to occur by July 15th, as the committee selecting a chair from among its members at the first meeting. A majority of the membership constitutes a quorum, and the committee ceases to exist on the date it submits its report, December 31st. Compensation and reimbursement, there's legislative compensation for the legislators serving in their legislative capacity for up to 8 meetings. That comes from the legislature's budget. And then other members are entitled to per diem compensation and reimbursement of expenses under a different statute for up to 8 meetings. That money comes from the Health Department appropriations. And then there is also the sum of $100,000 appropriated to the Department of Health from the general fund in FY24 that you talked about in your chart to support the work of the committee, including hiring a consultant to assist the committee in conducting its study and writing a report on its findings and recommendations. All right, then we get to to changing topics now, Medicaid dental cap removal report. This states legislative intent of the General Assembly to improve access to dental care for Vermont Medicaid beneficiaries by eliminating individual caps on dental spending. Following implementation of a proposed increase in the dental cap from $1,000 to $1,500 and evaluation of the financial impact of the increase, directs the Department of Vermont Health Access to project the potential costs of eliminating the dental cap entirely and requires the department to report its findings on those projected costs as part of its FY26 budget presentation. Right now we're looking at FY24, it would be in 2 years.
So Lori and I, we were talking about the word cap, and that's not equivalent to deductible, right?
No, this is Medicaid, so there are no deductibles. Deductible
Right,
is.
so that was what I was
cap.
talking about.
Right, so, do you want me to go through it again?
No, not everybody. I'll need help with this one. I
I've
mean,
got a question on that. Right now, if someone, gets a lot of dental work and it goes beyond the cap, do they pay all that remainder? Is it on them?
What we got, no, it's not on, you mean on who? Who's them?
On the patient?
No,
It isn't.
let me read what we got from Ginger. Hold on. Emergency dental services are subject to the cap. The change put forward in this proposal is that after a member meets the cap, emergency dental services will be covered after the cap has been met. If a patient receives emergency dental services before the cap has been met, those services will count towards the cap.
How about non-emergency dental services, okay? Unless you consider,
So
speaking of cap, getting a cap.
preventative work is not included in the cap at all.
Right, I understand that, but are they considering anything else emergency dental service?
I don't know the answer.
I see emergency dental as I get hit in the mouth with a baseball, it knocked my teeth out, I gotta go in and get them fixed, versus I've got a root canal. Root canal itself is beyond $1,000, I'll tell you that right now.
Right, that would not be preventative.
Pardon me?
That would not be
it
preventative.
would be emergency. It could be emergency.
Well, it is an emergency, it's normal
So
and customary service.
Emergency is pain, infection, and bleeding.
Okay, so
Need a root canal.
I'm not understanding here, so.
All we're asking them to do is come back with information and a cost of what it would be to completely eliminate a cap.
But I'm asking who pays beyond the cap?
And I don't think it matters.
Doesn't matter.
Why wouldn't it matter?
Well, all we're asking them in this
Right, there's a
is to look at
I
it.
get that.
No, but I'm struggling here too. If someone owes, has Medicaid and they have emergency care that costs $2,500, then the patient is going to be responsible for anything over the Medicaid cap.
So what I'm gonna suggest, because we have 20 minutes to finish this, and that this doesn't need to be answered for this language, that we have Ginger come back in and give some more information about the dental piece of this.
She is coming in tomorrow on a different bill.
Exactly, and I think we're talking about dental in that bill. Thank you. So let's hold that till tomorrow. Thank you. I just want to make sure we get through what's at hand here.
Okay, and then the last thing that is in here is, and I don't know that you have talked about this here, but the very short version is that there is a healthcare claims tax. A portion of that, 0.199% of the 0.999%, is dedicated to the HIT Fund for Health Information Technology. That piece of it, that 0.199, is scheduled to sunset on July 1st of this year. It was originally enacted, I believe, in 2013 and has been extended for 2 years ever since then, so that the legislature comes back and revisits this issue. So the governor's recommended budget included extending the healthcare claims tax sunset for another 2 years, but it did not reflect the necessary language to actually do that. So there's two pieces of it, both the tax side and the revenue side, that need to happen. And there's been a lot of confusion around this in the past. So I worked with a colleague and we fixed it up the way we think it needs to read. So if you want to recommend extending the sunset, this is the way to do it and not the way it was in the governor's recommend. That's really what it means.
So this is ensuring that we do what we really wanted to do, which is extend it.
Right. So if you want to extend it, please suggest this new language.
And Jen, did you say you talked to the administration about this?
I did not, but their proposal
is to
purports to extend it for 2 years. It just doesn't actually do it right.
Okay.
So, happy to talk to them, but
This does what they wanted, yes.
right, this does what they wanted. This does what they thought they were doing.
Yeah.
And it's very confusing and gets messed up frequently, so it's not a ding on them. It's just, a colleague and I looked at it.
Okay, so we will be adding all of that to our letter. The last thing we need to talk about is the language we want to put to tell appropriations why we did what we did. This doesn't need to be long. Bobby might have tried to come up with something. I know Brian also sent me a text with some. So let's, so just before we go to Bobby, we don't need to do this, but I think it's really important for us to provide some context. What we're trying to do in this committee in supporting our community-based providers and our preventative services. So Jen, are you ready to take notes?
Yeah.
Okay, so Bobby, did you come up with something?
I didn't know, I hadn't written out,
Okay.
I just wrote our notes from what we said, wanted to include, but I had something along the lines of every dollar that we spend in Medicaid is preventative and is likely to save multiple dollars down the road if for treatment that's deferred. And then the notes that we had was to stop underfunding Medicaid providers, we'll stop providing services to people, or fewer people will get treated. It takes pressures off of other providers, and it not funding Medicaid raises the cost down the line for other services. So I'm sorry, I didn't realize.
No, that's okay. No, you're fine. Nope, that's okay. So we're gonna.
Tired of Band-Aids, I wrote down.
Not doing Band-Aids. Brian, do you want me to read yours?
Yeah, you could read it for me if you want, since I'm on the floor and I don't.
Okay. So this is what, a little bit of what Brian, this is not a little bit, this is what Brian recommended, is the intent of the Vermont General Assembly. I would say the intent of the House Healthcare Committee to sufficiently fund the essential services of our healthcare and human services system provided by primary care, doctors and their staff, and all other outpatient mental health and substance abuse service providers in private practice and at DAs and SSAs. We must account for the impact of increased cost of doing business due to inflation and for the failure of the General Assembly. I would take that out and just say,
that's it.
and for the failure to adequately fund these services in the past. And it's not just the General Assembly that's failed. So that's an idea.
So what I heard you say this morning, if it's helpful, was that we can't keep underfunding community-based systems by underfunding Medicaid or failing to adequately fund Medicaid. It causes providers to struggle to provide quality care, it reduces access, and it increases costs for other payers.
That sounds great too.
Yeah, I think anything that's positive, I
Yeah.
don't think we have to get negative.
And I do think, sorry, I'm getting to you, Leslie. I do think we need to specifically say Medicaid.
Yeah, oh, absolutely.
Yeah. Leslie?
I think one of our guiding principles is addressing barriers to accessibility, affordability, sustainability, and efficiency across the system. I'm not sure if we want to say, consistent with our guiding principles, we have chosen to support these because we are aiming to, aim to improve. I mean, there are a couple of them there, I think, that are very relevant. And I'd like the idea, I'm not sure if it's appropriate in this case, because I've never done this before in this case, but.
I'm not sure I would put in language, due to our guiding principles. I think we use that in this committee to guide us to our decisions. But I think in what Jen just read, accessibility or access is there somewhere as, and I don't know if we use the word affordability, but we said we're underfunding Medicaid, so.
And the sustainability issue, I think, comes up in
Right.
several
Yeah, I
places.
think that's-
I'm just looking
yes.
at the words that have come up.
Yeah.
Efficiency also. Are providing excellent care.
Yeah, no. Just so I understand the process, which I should know after 2 years, but don't really, 'cause I guess I never figured it out, but we're gonna submit this to appropriations. And they're gonna look at it and they're gonna do whatever they're gonna maybe pare it down some.
Oh,
I don't
they're
know.
gonna pare it down.
No.
Let's be clear.
I know. And are they gonna do that with you? Are they gonna go back and forth with you as a community? How
So
does?
what will happen is we will present our information. We will, as our budget liaison and chair, we will
You'll
go
do
in
that.
and
You'll-
present, just like we did with BAA. We will present
Okay.
what we and why. And they do that with all the committees, and then
Yeah.
they do what we just did in some format, right? Which we can all now watch on Zoom or YouTube.
Yep.
And they will get to a number. They might come back and ask us clarifying questions, but it's really in their hands at that point.
Okay, so you're gonna present and they're gonna go with it from there, and that's how it kind of,
And then it comes to the floor for a vote.
gotcha.
Yep. And I want to be clear, whatever the straw, and we're just going to do a straw vote on this, right? If you vote one way for the straw poll, you can vote a different way, because then we're looking at this in the context of a whole budget.
Oh, yeah.
So normally where I would say you should support the committee on the floor, even if you voted no, you just, maintain your silence on the floor. But with the budget, you're looking at the whole thing. So if you want to vote yes here and no there, that's fine, or no here and yes there, that's totally different bill.
Gotcha.
Before we move away from the language, I know it's gonna be short, but I feel like it's important to say something about our intent to kind of move upstream. You said Band-Aids. Just to expand on it, I think, I thought about this in terms of making really strategic investments. Because I think it's been said many times in a lot of committee rooms, the importance of kind of getting upstream. And if we can kind of get at that, because I think it also aligns with the budget that was proposed to us, as well as the requests that came in. And it came up in a lot of conversations. Prevention and being preventative in care.
So there's two things, the old fashioned proverbs, like, an ounce of prevention is worth a pound of cure, and the stitch in time saves 9. And I'm thinking both of those have the logic that we want to include in this, about the money that we spend here prevents bigger problems that are much more expensive to fix down the road.
Exactly.
So just like you're saying upstream, there's another analogy, but yeah.
I forgot, I had that in my notes from you guys this morning. You said all of these things.
Okay, great.
You know what you want to say.
So for those of us that are new on this committee, Jen does a wonderful job of crafting language. So if she's open to it, I'm going to suggest that she put something together for this that she will do this evening. And I will send it to everyone when if you're on email tonight, great. I will send it to everyone. I want to make sure it captures the overall, but we will have to get this in, tonight or before committee tomorrow. So we won't be talking as a group about this. But Jen's very good at capturing what our thoughts are. I've heard what everyone's trying to get across. So we'll make sure something's put together and it's sent out to everyone. Okay. And just for historical purposes, when we've done these budgets in the past, before we went to this chart, so you would remember, we used to have, she would remember, like long, like 3-page letters, all words, like 10 pages. Letters, I mean, first couple of years, we were here late into the evening drafting these long letters. So really doing this and then having a summary of what our intent is, I think gets the point across much better. Because I don't know about you all, when I get to by the time I get to the second page, it's really hard to focus. So
I can't remember what was
on the first page, right, exactly. So we will clean up the chart, we will add the language, we will come up with a summary, we will send everything out to everyone. Thank you for everyone. Your questions were great. You came to the table willing to do the work, and we did the work as hard as it was. So you have earned your work for today. So thank you. We're done with budget, and we will pick up with H206 tomorrow, which is the technical bill. And we also have a joint meeting with House Education. So it'll be in this room, we'll be on Zoom. And we're going to hear from Agency of Education and Department of Health and their struggles with obtaining federal funding that's available to schools for mental health. On the line with us will be a representative from Welch's, I was going to say Leahy, but Representative Balance, Senator Welch, and Senator Sanders' office, so that we can try to get them to help us apply for some money for schools and mental health. So that's tomorrow as well. And then I think we're doing a compact. So that's on the agenda for tomorrow. And then on Friday, and we are going to have a long floor potentially. So keep that in mind. And then Friday, my intent, we have the floor. We do our discussion about what we want to look at for suicide prevention. And then we are done at lunchtime or soon after to give everyone a break and get you guys out of here.
Thank you.
All right, we can go off air.
Yeah.
Thanks.